of you will be kept on mute so that the disturbance is minimal. Also, your videos will be use your Q&A option at the bottom of your screens or somewhere on the screen to be. I want to thank Smith Medical for their support for this session. They are also the producers of the new the high flow nasal oxygen devices. I think we can contact them if anybody is interested. And also the good news is that the previous webinars that we had, it is up on the www.mumbaiana.org, and there's a this is how you'll see it, and then you will be directed to the medical learning hub where the previous lectures conducted by all the professors and seniors will be available for the students free of cost. And that brings me to introduce one of my favorite personalities in anesthesia. Is Professor Bhavani Shankar Kodali. He needs no introduction, but I'm thinking some of the youngsters would have joined only a few weeks back. So this is what a big name in anesthesia looks like. Okay, so Dr. Bhavani Shankar Kodali, we used to introduce him as from Brigham's Hospital for many years. And now today I have the honor of presenting sir to you all. He is now the chief of obstetric anesthesia division at the University of Maryland Medical Center, Baltimore, where he wears multiple caps as well. He's the chief safety officer, and he's also the assistant director of the maintenance of certification anesthesia simulation center there. Anybody who knows sir or has attended even one lecture of his knows that he can speak on any topic on the in anesthesia, right from capnography, which happens to be his favorite, and I think he's world renowned over that for the capnography. He has a website www.capnography.com. I think he'll speak about that in his talk as well. Pregnancy, the pain-free labor, airway problems in pregnancy, transfusion. So anything safety in anesthesia, a lot of topics that I've heard myself speak on, and he has enthralled and he's educated so many of us through so many conferences. He has more than 140 peer-reviewed and invited publications. He writes extensively and he teaches extensively. So by the way, goes on for 74 pages, so I don't think we have any time for that. So I will stop again for being with us.
Sure, thank you. So I will start on the the lecture, and yeah. So good evening, everyone. Of course, it's good morning here, and good evening, everyone. And usually every 2 or 3 years, I do visit Mumbai, and that is how I knew Dr. Vijay Shetty, because at the meetings. And during the last meeting, in fact, it is about 5 or 6 years ago, I think. And you can recognize two people here at the one of the Mumbai's meeting. One is my mentor and guide, Professor Kangle, and she actually is in Mumbai, and she comes to our meetings whenever myself and Ramkumar comes there. And you can recognize the other person, my good friend, Pankaj Kundra. So because of this COVID, we are unable to meet in person. So I thought that I will do this webinar, because when Dr. Vijay Shetty called, I said, okay, that's fine with me. Now, I have to disclose a few things about capnography. I do own all these web names, capnography.com, .org, .biz, .net, or .us. They all belong to me, and any of these names come to my website, actually. And this is a fairly extensive website on capnography. And it deals with the physics, the physiology, the clinical applications in pretty much in all details. And whenever you have a chance, I would encourage you to go into the website to learn about capnography. Now, it is also a mobile version, actually. And if you actually use the QR code, it takes to the mobile version on the iPhone or the Android versions. And it is compatible in those versions too. Now, pulse oximeter is an excellent monitor of hypoxia, and we all use pulse oximeter. Unfortunately, one limitation of pulse oximeter is it only tells you that the patient is hypoxic but it does not tell you or give you any clue to identify the etiology of hypoxia. This is where capnography comes into picture. Capnography can potentially help to identify situations that result in hypoxia. Therefore, what happens is it gives you certain clues, and you can use these clues to figure out what is wrong with the patient that is causing hypoxia, so that you can take preventive actions within the 3 minutes before hypoxia produces irreversible damage. And another important thing about capnography is it helps to actually prevent hypoxia, because it is going to forewarn about clinical situations that could potentially result in hypoxia if you do not take corrective measures based on the capnography clues. But one thing you have to remember here is pulse oximeter is a direct monitor. That means it tells you whether the patient is hypoxic or patient is not hypoxic. Whereas capnography is not a direct monitor, it is an indirect monitor. What it means is, in order to diagnose a clinical situation using capnography, you have to understand capnography thoroughly so that you can make a corrective assessment and diagnosis of a situation, of a clinical situation that could either leading to hypoxia or potentially can lead to hypoxia. Now look at this example. This was before the era of capnography. They gave general anesthesia for a cesarean section and the patient would not wake up. When they did the blood gases on the patient, they found that the patient was oxygenating very well, but the patient has got a PaCO2 of 246. And this is beyond the CO2 narcosis value of 110. And therefore, this patient is in probably CO2 narcosis coma. And this is because of a problem with the ventilator they were using, that there was a malfunction of the ventilator and therefore it was not eliminating the CO2. And once they changed the ventilator, patient woke up. This could not have happened if capnography was used, because it could have immediately given a clue that the end tidal CO2 is going to be very high in this patient. Now, these are the standard monitors of ASA, and which also includes capnography in their armamentarium. And this probably, capnography was introduced as a armamentarium of a minimum standards in probably in the mid 80s in United States, and subsequently many other countries followed that. But it is noteworthy to know that Holland was the first country in 1978 to make capnography as a standard of care during anesthesia. Now, normally you measure CO2 waveform or the CO2 at the junction of the patient circuit here and the anesthesia circuit here. Because you are monitoring the CO2 between these two circuits, it can actually give you some idea about what is going on in the anesthesia circuit and what is going on the patient circuit. The only thing, as I said, is it is not a direct monitor. It will not tell you right away what is wrong. And that is where you have to use your knowledge of capnography to figure out what is wrong in a clinical situation. Now, just a little bit of physics. And now CO2 is a polyatomic gas, and therefore it absorbs infrared technology, or it absorbs infrared light. So there is a source of infrared there in the unit, and the CO2 absorbs the infrared light. The balanced infrared light is measured, and you know how much you're giving, you know how much you're measuring, and the difference between the two is quantitated into a CO2 waveform, which you see in your monitor on a regular basis. Now, what happens here is you have to remember the CO2 is a polyatomic gas, and this actually absorbs the infrared light at 4.3 millimicrons, and that is the wavelength where the CO2 molecules absorb. What about nitrous oxide, water vapor, which are also being concomitantly administered during anesthesia? Because they are also polyatomic gases. Yes, they do absorb CO2. I mean, they do absorb the infrared light, and the CO2 molecules absorb, the nitrous oxide absorbs, and the water vapor absorbs too. Therefore, many monitors actually give an automatic corrections for the error produced by nitrous oxide and water vapor. What about oxygen? Oxygen is not a polyatomic gas, therefore it does not absorb infrared light, and it uses, to measure oxygen, we use paramagnetic, because it's a paramagnetic gas, therefore we use technology suitable for it to measure oxygen. Now, although oxygen does not interfere with the absorption of infrared light, carbon dioxide molecules, nitrous oxide molecules, and oxygen molecules, they collide with each other. And therefore, what happens is, it is called as it produces an interference in the absorption spectra of the CO2, of the infrared absorption. And therefore, the monitor also gives correction for this collision, broadening effect. Now, what happens in our clinical use? In general, the clinical use, the errors produced by these are minimum, and therefore we need not worry about the errors produced by these in a clinical practice. However, if we are doing a physiological experiment, you have to remember this: the interference of nitrous oxide, interference of water vapor, and the collisioning broadening effect, and you have to give corrections for your measurements. Now, there are two sensors in clinical practice, which is the mainstream sensor, where the CO2 is actually measured across the airway. That means the whole cuvette containing the sensor is within the patient airway at the junction of the endotracheal tube and the circuit. In a side stream sensor, the CO2 or the expired gases are drawn via a tube of 6 feet length into this monitor where the measurements are made. So there is a lag of CO2 measurements compared to the actual events or the respiratory events in the patient. In clinical practice, the common technology is a side stream sensor. I think that is what you must be using mostly in your clinical practice, but many also use the mainstream sensor to measure CO2. Now, a little bit of physiology. I think once you understand the physiology of capnography, it is extremely easy, it becomes extremely easy for you to actually understand capnography and apply to the clinical scenarios. When you breathe out and take a fresh breath of oxygen, and then you breathe out and start measuring CO2, this is how your CO2 waveform looks like. Initially, the CO2, there's no CO2 because it is dead space gases. Then the dead space gases are mixed by the alveolar gases. Therefore, there's elevation or increase in the CO2 concentration. And then there is alveolar gases here, which is the CO2 coming from all the alveoli. Then you take the next breath, and if the next breath does not contain CO2, then the CO2 concentration falls dramatically. So basically, this is how your capnogram looks like. It has got an expiratory segment here, and it has got an inspiratory segment here. And the shape of the capnogram is similar or identical in all healthy adults. A deviation from this shape requires requires evaluation to determine whether it is a physical, physiological, or a clinical aberration responsible for that difference in the shape of the capnogram. Now, earlier, this is way before, say, before 2000, many clinicians were using several nomenclature, to say what is a CO2 waveform looks like, PQRS, ABCD, etc. But in the middle of 1995, we came up with a standard terminology because CO2 waveform resembles the classic physiological nitrogen curve. The nomenclature should also reflect same. So this is the phase 1, which is the dead space gases, and this is the phase 2, which is the dead space gas mixing with the alveolar gases, and this is phase 3 from the alveolar gases, and this is the inspiration or the inspiratory segment. The angle between the phase 2 and 3 is called as the alpha angle, and the angle between the phase 3 and the descending limb is the beta angle. This alpha angle is about 110 degrees normally, whereas the beta angle is about 90 degrees. Now, I will explain to you shortly that the phase 3 is actually a reflection of the ventilation perfusion mismatch in the lung. So alpha angle in essence is a reflection of the ventilation perfusion matching in the lungs. Now you can also plot CO2 against the volume. See, this is the CO2 against time. So there is an expiration and inspiration. But when you plot CO2 concentration against expired volume, there is no inspiratory limb because you're plotting CO2 concentration against one expired volume. The advantage of plotting the CO2 concentration against the expired volume is it will help you to determine the effective alveolar ventilation, the physiological dead space, and the components of physiological dead space like the anatomical or the alveolar dead space. So in essence, a volume capnogram can be used to determine the components of the tidal volume, namely the effective alveolar ventilation and the physiological dead space, which are very important in our clinical practice. Now, the maximum concentration of CO2 at the end of the breath is called as the end tidal CO2. The end tidal CO2 is slightly lower than the arterial CO2 because of the alveolar dead space. So in one way, we can say that the arterial to end tidal CO2 difference is a reflection of alveolar dead space. Occasionally, you can get a terminal upward blip at the end of the phase 3, and this is called as phase 4, and this is seen in morbidly or obese patients under anesthesia, and also it is seen in pregnant women. To understand why phase 4 occurs, I would recommend that you go to my website and look under physiology and phase 4. You will understand why phase 4 occurs in our in our clinical practice. Now, when you look at the ventilation of the lung, the bottom of the lung is better ventilated than the top of the lung. That is the normal physiology. When you look at the perfusion, the bottom of the lung is better perfused than the top of the lung. So in other words, the lung is better perfused and ventilated at the bottom of the lung compared to the top of the lung. But there is one important difference. When you plot the slope of the increase in ventilation from top of the lung to the bottom of the lung, they do not follow a similar linear pathway. There is a difference between how they increase from top of the lung to the bottom of the lung. Because of this, the lung has got various VQ alveoli. That means various VQ ratios. That is which you always, you say zone 1, zone 2, zone 3, etc. Now, the top of the lung has got alveoli where the ventilation is more related to perfusion, whereas the bottom of the lung, the VQ ratio is lower because the perfusion is more compared to ventilation. Now, physiologically, Whenever the ventilation perfusion of the lung is low or the ratio is low, they contain more CO2. When ventilation is more than the perfusion, they contain less CO2. This is a normal physiology. Now, when such a lung where the CO2 concentration is more at the bottom of the lung compared to the top of the lung, when it begins to expire, it gives you this classic shape of capnogram, which you see in your clinical practice. Now, the point why I'm explaining all this is, when you look at this alveolar plateau, it is not simply a line. Capnogram is not simply just a CO2 waveform or a line like this. Just by looking at the capnogram, you can know exactly what is happening within the lung, particularly in terms of ventilation perfusion ratio or the ventilation perfusion status of the lung. This is how I see capnography, and this is how I want all of you to see capnography. Now, the height of the capnogram is dependent on two things, the ventilation and the perfusion, because of the, as I said, alveolar plateau reflects the VQ status. So whenever the cardiac output decreases or increases, it is reflected in the end-tidal CO2. So if you keep your ventilation constant, the end-tidal CO2 indirectly reflects the cardiac output. If the cardiac output of the patient is 2 liters, the end-tidal CO2 is roughly about 20 millimeters. And this is something very useful when I talk about CPR. Now, normally what happens is the end-tidal CO2 is measured in concentration, or if you know the atmospheric pressure, you can convert into millimeters of mercury, and normally it is about 36 millimeters of mercury. Since the capnography waveform is also dependent not only on the perfusion, on the ventilation, when there is an abnormality of the ventilation, it also alters the shape of the capnogram. And this is the classic presentation of a COPD or bronchospasm. And when you give bronchodilators to this patient, it reverts back to the normal capnogram. So whenever I intubate someone, if I see this abnormal capnogram, then I know that I have actually produced a little bit of bronchospasm because of the reactive airway disease, or patient may be having a COPD or bronchospasm because of asthma. So it gives me an indication right away whether I should treat or not. Now, as I said, the end-tidal CO2 and the arterial CO2, the normal difference is about 4 to 5 millimeters. Therefore, the end-tidal CO2 is a reflection of the arterial CO2, and the difference generally indicates the alveolar dead space. Now, whenever you look at capnography, you have to look in a very methodical fashion. What is the frequency of the waveforms? That means at the rate. What is the rhythm, whether it is regular or irregular? The height of the capnogram, as I told you, that if your sampling is good, then it reflects the CO2. It reflects the cardiac output. Then what is the baseline, whether it is coming back to zero, and what is the shape of the capnogram? If you look at the capnogram in this fashion, it gives you substantial information in a given clinical scenario. So whenever you apply, whenever you do the clinical applications, you have to actually look at the values, the end-tidal CO2 values, whether it is low or high. You can look at the shape. The shape of the capnograms gives you some indication, because the shape of the capnogram is specific in certain clinical circumstances. Then, if you know the arterial value, if you have an A line, for example, and you know the PaCO2, the difference between these two gives you an idea about alveolar dead space. Now, let's look at some of the clinical applications. The first and the foremost is airway integrity. Now, When you are monitoring CO2 and it suddenly disappears, the first thing, of course, you have to check whether there is that your monitor is not disconnected and it is working. But the important thing is it could reflect a circuit disconnection. When a circuit disconnection, there is a complete apnea, or the patient has stopped breathing, because if the patient is spontaneously breathing and you have given a lot of sedatives or narcotics and patient has stopped breathing, so it immediately draws your attention to the patient. Now, confirmation of intubation or misplaced endotracheal tube. When the tube is placed into the esophagus, you do not get the normal CO2 waveform which you are expected to see. You may get a little bit of blips of CO2 because there is some amount of CO2 is always present in the stomach, or particularly when you are ventilating a patient before intubating, you may push some airway from the CO2 from the airways into the stomach. So that is an important, but however, when you do little bit of ventilation or few ventilation, this CO2 will get washed off and you will get a straight line. But the point of this is, if you are not paying attention to the CO2 waveform after intubation and your CO2 waveform is flat, always consider that if it could be a failed intubation. Many clinicians who were so confident about their intubation, saying that they really put the tube into the trachea, but did not get CO2 because in a state of denial, later on found out that it was an esophageal intubation because patient had hypoxic cardiac arrest. So whenever you get a flat CO2 after intubation, requires your attention right away. And this I have already told you, a normal CO2 waveform versus a bronchospasm or a COPD, and that requires your attention whether to treat this patient or not. What about ventilation? Now, as I said, normally the CO2 waveform or the end-tidal to arterial CO2 reflects alveolar dead space. However, when the cardiac output of the patient is changing because of hypotension, hypertension, or changes in the pulmonary blood flow, the alveolar dead space also changes. Therefore, the end-tidal to arterial CO2 different, also changes. So in some ICUs, because of the variations in the ventilation perfusion status, the arterial to end-tidal CO2 will be also changing. And that is the reason why many clinicians think that using capnography in ICU setting is worthless. But unfortunately, they are wrong. The reason is, if the arterial to end-tidal CO2 difference is narrowing and is stabilizing over the course of the ICU stay, what does it tell you? It tells you that whatever treatment you are giving to this patient is actually working, because it is actually either decreasing the alveolar dead space or it is stabilizing the alveolar dead space. So this has got a very important use in the ICU settings. This is the classic hypoventilation. When someone is hypoventilation, the CO2 height goes up and therefore the end-tidal CO2 also goes up. And this is the hyperventilation, which you see very often in your clinical practice, because as you continue anesthesia for a while, you're actually decreasing the metabolism of the patients and therefore the CO2 production. And therefore, there is a relative hyperventilation to this patient with time. And therefore, you adjust your ventilation to bring your CO2 back to normal. This is just a sedation capnogram, which we talk a little later too. These are the capnograms before sedation, and you see what happens to the capnograms later. There is the respiratory rate has decreased, and here you see the height of the capnogram has decreased because of oversedation. Now, how does cardiac output affect end-tidal CO2? I'm just repeating this again because this is very important in our clinical practice, that it linearly reflects, the end-tidal CO2 linearly reflects cardiac output. Now, this is the normal, say CO2 is 37 here. and there is a liver, there is an abdominal surgery or the liver resection is going on, and there is a substantial loss suddenly. And because of this, the cardiac output decreases and end-tidal CO2 decreases. So whenever end-tidal CO2 decreases for a given ventilation, dramatically, you must look at the other side of the drapes to see if there is substantial blood loss. So this does help because, as I said, that end-tidal CO2 reflects cardiac output. And if you do not do any corrective measures, if you do not resuscitate such a patient, the cardiac output keeps decreasing, the end-tidal CO2 keeps decreasing, and finally there is a cardiac arrest, and you begin to revive the patient, and as the cardiac output increases, you see how the end-tidal CO2 increases. Next time, whenever you happen to have a bad case and then you get into a situation like this, you can see the trend of CO2 to reflect what happened to this patient in the prior to, before the cardiac arrest and after cardiac arrest. Now, what about air embolism? And if you're doing a neurosurgery case and the end-tidals are pretty good at 36, and then suddenly the end-tidal decreases, this could be because of air embolism, particularly if you're doing a craniotomy. Because what happens is when the air gets sucked in from the sinuses, from the venous sinuses, and then produces an airlock in the pulmonary artery, therefore decreases the pulmonary blood flow, therefore decreases the cardiac output, therefore decreases the end-tidal CO2. So this, although echocardiography is the most sensitive to detect air, during air embolism, nonetheless, end-tidal CO2 is number 2 in the list. What about thromboembolism? You will be doing cases with hip replacement or fracture of the femur, and they are prone to a lot of thrombosis. And when suddenly the end-tidal CO2 decreases, you can see that probably the patient could have developed thromboembolism. This actually reminds me of a situation that happened almost like about 15, 16 years ago. I gave this lecture to residents on a Tuesday. On a Wednesday morning, the resident was doing a hip surgery, and suddenly the end-tidal CO2 actually decreased, and immediately he called for help. And one of the differential diagnoses he remembered was the thromboembolism, and they did a transesophageal echo, and they found the patient has a large clot in the pulmonary artery, and the patient, instead of getting the hip surgery, got a cardiac surgery, went on to the bypass, they did the embolectomy, and the patient subsequently had hip surgery 2 weeks following the cardiac surgery. Now, when you have a patient on the ventilator or even during anesthesia and the patient is recovering, you can see some spontaneous breaths along with the ventilatory breaths. When the height of the spontaneous breaths is same as the ventilatory breath, what does it tell us? It tells us that the patient's respiratory effort is more or less equal to your ventilatory breath and therefore probably ready for extubation. What happens in pediatrics when you actually measure capnograms or when you use capnography? The waveforms you get in the pediatric capnograms could vary. All these shapes are normal in children. The reason for that is the capnographs we use, the response time of the capnographs we use is longer to measure CO2 very quickly when the tidal volumes are small and the respiratory rates are more in children and the infants. However, the new technology of CO2 monitoring, which is called as the microstream technology, actually uses 50 ml of sampling flow, but with a greater accuracy, and you can get same shape of adult capnogram shapes even in a small neonate with a very small tidal volume. So the current technology is very helpful to get a normal shape of CO2 waveform even in neonates with a very low tidal volume or small tidal volume. However, if you are using a regular monitor, sometimes you can get all these capnograms in children and they are normal. Now, if you're doing aortic surgery, like cross-clamping, when you cross-clamp during aortic surgery, if the end tidal CO2 decreases greater than 15% from the baseline, or yes, when it decreases more than the 15% from the baseline on cross-clamping, then when they unclamp, the systolic blood pressure could be greater than 20. What I'm trying to say is, when there is a decrease of end tidal CO2 during cross-clamping, that shows that the collateral circulation in that patient is not sufficient, and therefore this patient is likely to have more hypotension when they unclamp. So it actually gives you an indication even before unclamping that I must be prepared with volume and vasopressors because I may expect hypotension on unclamping of aorta. Now, what about laparoscopy? Now, it is mandatory to use capnography during laparoscopic surgery. If CO2 monitoring is not used in laparoscopic surgery in the current day or for today, I think it may amount to a criminal negligence on the part of anesthesiologist, because it is essential to monitor CO2 during laparoscopy, because you are actually insufflating CO2 into the abdomen during laparoscopy. It helps us to diagnose embolism. It helps us to understand the ventilatory adjustments, whether we need to increase ventilation, otherwise the patient will have respiratory acidosis and with low pH. And it also allows us to diagnose complications. In thoracic anesthesia, the best way to figure out where your double-lumen tube is placed is using bronchoscopy. Nonetheless, capnography also helps. Now, this is a normal CO2 waveform coming from the lungs, and suddenly the CO2 waveform changes its shape. That tells us that this double-lumen tube could have dislodged or obstructed, and therefore will allow you to immediately intervene. And when you correct the scenario, you get your normal CO2 waveform back. This is just an example of a lung transplant case where CO2 is where the CO2 waveforms were recorded. This is a dual waveform. This is the initial part of the lung, the transplanted lung, where the transplanted lung is trying to, slowly get better with the ventilation perfusion mismatch of the ventilation perfusion status of the lung. Now, when you are measuring CO2 from a double-lumen tube, this is how it looks like in a single lung transplant, because this is the CO2 coming from the old lung, and this is the CO2 waveform coming from the transplanted lung. And when you mix both of them, this is the classic shape of CO2 waveform after one lung transplant. Now, as I said, this is, you monitor CO2 between the anesthesia circuit and the patient circuit. And any of these changes that occur in the patient actually is reflected in the CO2, because you are measuring the CO2 here. It could be an esophageal intubation, accidental extubation, or disconnection, apnea, hyperventilation, hypoventilation, and rebreathing pertaining to the lung. It could be reduced cardiac output, hypovolemia or hypotension, or it could be the CO2 production that is decreased or increased. When you release tourniquet or you give sodium bicarb, there will be an increase in the CO2, and therefore your CO2 output could be increased. Then when there is a pulmonary embolism or cardiac arrest, it is reflected in your end tidal CO2. Similarly, airway obstruction, bronchospasm, and respiratory patterns and the VQ mismatch is reflected by CO2. But as I said, and any of these ventilator issues, circuit kinking or the ventilator malfunction. And that is the reason, as I said, since it's an indirect monitor, you have to look at the CO2 waveform here and see what is happening around, whether it is a problem in the patient circuit or in the patient or in the problem with the ventilatory circuit. And if you understand the physics, the physiology, and the clinical applications of capnography, you can easily figure out what is happening to a patient, and you can rectify the hypoxic situation or prevent hypoxia to occur. Now, what about capnography used in the CPR? Now, it is a rescue device in CPR. If the patient is dying, it actually helps to pull the patient back to life. How? It is the most reliable method of confirming the correct placement of endotracheal tube. Because when you are giving chest compressions and measuring CO2, you should get these blips. If you are not getting these blips of CO2 during chest compressions, that means your endotracheal tube is not in the trachea. And this is the reason why every patient in the ICU where the cardiac arrests are more likely to occur should have capnography, because it not only tells you whether the tube is in the trachea, but it also confirms to help. It also helps during the resuscitation process of CPR. The optimum chest compressions during CPR generates a cardiac output of 2 liters. And I showed you that a cardiac output of 2 liters corresponds to about 20 millimeters. So you must always perform chest compressions in order to produce the end-tidal CO2 values between 10 and 20. If your end-tidal CO2 values are consistently less than 10 millimeters, either your chest compressions are not good, or if you are giving adequate chest compressions and your end-tidal CO2s are less than 10, then it is associated with poor outcome. So this is the value of capnography in CPR. That is why the American Heart Association in their ACLS protocol has implemented capnography into their practice. And this is the picture, as I want you to again remember that the cardiac output is indirectly reflected in CO2 measurement. And a 2-liter cardiac output corresponds to about 20 millimeters of CO2. Now, when you are giving chest compressions and suddenly there is an increase in CO2 measurement, what does it tell you? It actually indicates the return of spontaneous circulation. That means whatever you did to this patient for resuscitation, the patient's the heart has started spontaneous rhythm and is generating cardiac output, which is reflected in your increase in the end-tidal CO2. Now, this is a very interesting case. Actually, this patient collapsed in a supermarket. So the ambulance comes in and then they do a CPR. This ambulance was joined by advanced, life care cardiac support ambulance, which is equipped with capnography and, etc. They intubate this patient and they measure the CO2 during CPR. They do the CPR for about 20 minutes, and finally they think of calling off and declaring the patient dead. However, one of the nurses in the group has substantial experience with capnography. She called the Mayo Clinic emergency room and told them that the end-tidal CO2 of this patient is consistently over 25 during CPR. What they advised is continue CPR and continue giving shocks. They gave about 13 to 14 shocks, and finally the patients had got spontaneous rhythm. And the patient was flown to Mayo Clinic, and they do an emergency cath and then remove a large plaque, and the patient made complete, a very good recovery. and he was actually interviewed in one of the TV channels, and where they showed the value of capnography during resuscitation. Although this patient had CPR for 96 minutes, we do not know when to start CPR, and there is some research going on in France to determine how long one should continue CPR when the end-tidal CO2s are pretty good during chest compression. And also, this also helps as one of the parameters of head cooling after CPR or after cardiac arrest. Now, almost about 6-7 years ago, many societies have introduced capnography to monitor CO2 during moderate to deep sedation. It is more or less mandatory in many countries to monitor CO2 during sedation. Why? The reason is the incidence of hypoxia is less if capnography was used to monitor ventilation during sedation. That is number one. Number two, we do not know how an individual will respond to a given amount of sedation. Some may respond little more than the others, and they can go into apnea. Now, capnography, when used in conjunction with the pulse oximetry, detected respiratory depression more often than without capnography. And also, capnography forewarns of impending hypoxia, because capnography can tell you that the patient has hypoventilation or apnea during sedation, and immediately you can take steps. If you don't take steps, the patient subsequently becomes hypoxic. And sometimes because you are giving oxygen to these patients, it actually delays the onset of hypoxia despite apnea. And this is where capnography helps us to prevent an upcoming hypoxia in a given patient. And this I have stressed, and many clinicians stress now, is administration of supplemental oxygen delays the onset of desaturation following apnea. And therefore, relying on pulse oximetry alone will delay intervention. Now, these are the capnograms that are recorded in sedation. Now, because you're putting an oxygen mask and you're giving oxygen while recording CO2, the shape of the capnograms may not be exactly same as an intubated capnograms. And that is good. You take this as your baseline capnogram before you administer sedation. And any change from the baseline to subsequent capnogram should alert you the effect of sedation. Here you see the respiratory rate is decreased. In this case, you look at the height of the capnogram and look at the height of the capnogram here, and this is decreased. This immediately points to whether the hypoventilation or respiratory obstruction because of sedation. The way I use capnography during sedation is I put a nasal cannula, as you can see here, just to monitor CO2. And then I put an oxygen mask to give oxygen. And look at the CO2 waveforms and look at the end-tidal oxygen. I'm giving oxygen here, but look at the CO2 waveforms. They're pretty normal in shape. So you can use your ingenuity in any case to get close to perfect CO2 waveforms before administering sedation. And this is a case of endoscopy where I'm monitoring the CO2 here. I made a small hole in the oxygen mask so that they can put the endoscope and perform the procedure while giving oxygen and also measuring CO2 waveform. And look at the CO2 waveforms; they're pretty okay, good size here. So the point nowadays, actually, there are many new masks are available where with a slot for putting the endoscopes while simultaneously measuring CO2 and administering oxygen. Now, I'm going to give you some homework, and these are all the capnograms, various shapes. You can actually study each of these capnograms. And how you want to do that is you go to Google and put capnography outside the operating room, And one of the first papers that comes is an article which I wrote for anesthesiology, capnography outside the operating room. And this is the article here. And when you look at this picture, there's a nice color picture there with all these shapes, and this actually explains each of these capnograms. And please look at this as your homework, so that with the background of physics, the physiology, and the application I explained, you should be able to easily understand these various abnormalities of the CO2 waveform and how they are produced. So now let us go and for a small quiz. There are 11 questions, and let us see how you perform and how you understood this capnography. Don't worry, even if you make a mistake, in the end anyway, I will tell you the right answer. So the first one is carbon dioxide absorbs IR light at what wavelength? 3 microns, 4.3 microns, 4.3 millimicrons, and 8 microns. And this is your time. And you get, I think, about 20 seconds or 15 seconds. See what you come up with. And then I will give you the answer. All right, so 37% got it right, 4.3 millimicrons, and that is the that is the answer. And it is not 4.3 microns, it is 4.3 millimicrons. So that's good. So we go to the next one now. Phase 3 capnogram is due to dead space gases. Phase 3 is the alveolar plateau, or mixing of dead space gases with alveolar gases, evolution of CO2 from the alveoli, and none of the above. All right, that's good. So expired gases from the alveoli, that's very good. So this is what I was trying to say, that whenever you look at the CO2 waveform, don't simply look at, oh yeah, I see some lines. Look at that phase 3 or the alveolar plateau, because that actually reflects your ventilation status of the lung. And as soon as actually I enter an operating room, where the case is being performed, I look at the CO2 waveform, and immediately that gives me complete clue. Yes, the patient has good cardiac output, the patient has got normal ventilation perfusion status, etc. and etc. Very good. Arterial to end-tidal CO2 difference specifically represents anatomical dead space, apparatus dead space, alveolar dead space, none of the above. Wonderful. Alveolar dead space, correct. Arterial to end-tidal CO2 difference indirectly reflects alveolar dead space. And for those of you who are really interested in volume capnogram, you can actually check out I think on the Indian forum, myself and one of my fellows wrote an article on volume capnography. And nowadays, volume capnography is being used to measure Bohr's dead space, which is the original Bohr's dead space, not Enghoff's modification of Bohr's dead space, but original Bohr dead space. But that is entirely a different topic. But I just wanted to let you know. So let's go to the next one now. So this is a capnogram, occurs in bronchospasm, COPD, significant kinking of the endotracheal tube, all of the above. Correct. I think you all got it right. It is all of the above. Now, bronchospasm, yes. COPD, yes. Significant kinking of the endotracheal tube. See, any obstruction, expiratory obstruction leads to that kind of capnogram. An endotracheal tube obstruction greater than the 50% of the diameter of the tube can result in abnormal capnogram. So that is the reason I gave this question too. Very good. So we'll go to the next one. Which one of the capnograms can be seen in the pediatric subjects? A only, B only, C only, D only, A, B, C, D. Very good. So yes, as I said, all of these capnograms can occur depending upon the type of the monitor you're using. But as I said, the new technology, well, it is not no more new technology. The microstream technology has been there for over 20 years now. And that technology is a very good infrared technology. It uses less sampling flows. It is a side stream monitor and gives you a perfect CO2 looking waveforms in a very, very small neonates, even in the premature babies. So the technology is improving. And the reason why you get these abnormal CO2 waveforms is the response time of the currently available monitors or the adult CO2 monitors may not be as good to respond to the CO2 changes because of the high respiratory rate and low tidal volume in newborn and small children. But however, the technology has improved substantially over the years, and you are getting normal looking CO2 waveforms in children and newborn. Next one. How is cardiac output related to end-tidal CO2? Linearly, inversely, no relationship, none of the above. Very good. Yes, it is linearly. That means as the cardiac output increases, the end-tidal CO2 increases. And the reason I put this question again is it is very, very important for you to understand, because when I give these capnography lectures at many places, some of the delegates come back to me, says that, that was a very good point, and they didn't know that end-tidal CO2 actually reflects cardiac output. And this is a very strong relationship between the end-tidal CO2 and cardiac output, and which we can use in our day-to-day practice. We'll go to the next one. What happens to end-tidal CO2 in pneumothorax? Prolonged phase 2 and 3, no change in end-tidal CO2, decrease in end-tidal CO2, all of the above. This is slightly difficult question, but I put this question because, yeah, first give me your answer. Okay. All right. It is actually all of the above. And as I said, it is going to be a difficult question. I put this question and I wrote about this on my website under frequently asked questions. So one day, I get emails from all over the world about capnography. And I got an email from Australia where in one of their fellowship exams, the examiner asked the candidate, what will happen to the CO2 during pneumothorax? And the candidate sent me that question. He says, I was asked about this question and I didn't know exactly what would happen. So I want your opinion. So what happens is the end-tidal CO2 here can behave, so when depending on the size of the pneumothorax, it can behave like an obstructive pattern because you're compressing the airway, so you can get prolonged phase 2 and 3. If the pneumothorax is small, you may have no change. Or if the pneumothorax is actually producing some sort of a compression effect like a tamponade, where the cardiac output decreases, then it produces a decrease in end-tidal CO2. So therefore, anything can happen in a pneumothorax depending upon the status of pneumothorax. And that is the answer it should be. So that is why I wrote this question on the website too. So let's go to the next one. Does end-tidal CO2 predict arterial CO2 during laparoscopic surgery? Yes or no? Okay, so actually you all got it mostly right. It is yes, it can predict. There are several studies where it showed that the end-tidal CO2 predicts arterial CO2 during laparoscopic surgery. Now, if the patient has got a substantial ventilation perfusion mismatch prior to laparoscopic surgery because of either lung problem or the cardiac problem, then it may not reflect. But those are exceptional, ASA status 3 or 4, where you may have to have an arterial line to monitor the PaCO2 during laparoscopic surgery. But in majority of the times, the answer is yes, it can predict. Let's go to the next one. Does end-tidal CO2 predict PaCO2 during LMA in anesthesia? LMA is laryngeal mask airway. Yes, very good. So yes, it does predict, and actually the difference more or less is same what you have in an endotracheal tube. That means the arterial to end-tidal CO2 difference. Now I got an interesting question once from one of the states, New Mexico in the United States, where they use combi tube. When the emergency ambulance personnel go outside, to get the patients, they put a combi tube on the streets. They asked me, how does end-tidal CO2 reflects the arterial CO2 during combi tube? Well, I told them I have no idea because I never used combi tube so far in my life. Touch wood that I don't have to use. But I suppose, if your ventilation is good, it could reflect fairly well. But I don't know the answer for that, for the combi tube. Let's go to the next. What should be end-tidal CO2 during good chest compressions in CPR? End-tidal CO2 less than 10 millimeters, end-tidal CO2 between 10 and 20, end-tidal CO2 has no value in CPR, return of spontaneous circulation has no impact on end-tidal CO2. Perfect. Correct. The end-tidal CO2 should be between 10 and 20. As I said, a good chest compression produces a cardiac output of 2 liters, and 2 liters is reflected by about roughly 20 millimeters on the end tidal CO2 for a normal ventilation, and therefore it should be used. It should be around that. And monitoring CO2 during chest compressions will actually improve our efficacy of chest compressions. If you are not getting good quality CO2 blips of 10 to 20, that means you can tell the whoever is giving the chest compression that you have to press little more in order to generate the cardiac output. Let's look at the next one if we have. Yes, we are on the last one. Capnography and sedation. Capnography has no value during sedation. End tidal CO2 value of 40 millimeters should be present all the time. A change in end tidal CO2 value or shape from pre-sedation is important during sedation, and none of the above. Perfect. A change in end tidal CO2 value or shape from pre-sedation is important. That is yes, that is absolutely correct. As I said, because you are measuring this from a mask or from a device, and there is a dilution by the air or oxygen you're giving, and therefore the shape may be a little different, the value may be a little lower, but what is more important is a change when you start your sedation. Good. I think we have done with our quiz, and I wish all of you good luck in your post-graduation, and also in your clinical practice and your future life. And hope to see you sometime.
Yes, sir. Thank you very much, sir. On behalf of all the delegates, we did a sincere thanks for this wonderful webinar that you have conducted. And I think you made full justice to the word masterclass that I used for this. It brings back to my memory all those lectures that I attended personally, and for so many of my friends, I'm sure it is. So we have a few questions. If you could I could just put it across to you quickly. Can I start, sir?
Sure, sure.
Okay, so one of the first questions is from Farhan. Farhan Madam Mukaddam, you want to know about data acquisition and analysis. Are you able to record a waveform in a digital format from the monitors? If yes, could you advise how we can set a data stream in the OTs and ICUs with the annotations preferably?
Sure. Actually, many of the ICU ventilators and also some of the, most of the CO2 monitors store the data of the case. You can actually go back and look each individual, you may not be able to store the waveforms, but you will be able to store the digital values of those numbers. And if whoever is the manufacturer of that unit is the best person actually to tell you how to get that printout of the data. And because for us, what happens is most of the data gets electronically transmitted to our anesthesia record. So our anesthesia record has got the digital values of end tidal CO2 and also the inspiratory CO2 periodically, every minute by minute. And most of this data can be saved within the monitor, but this actually requires little bit of discussion with the manufacturer of that unit, and they certainly will help you to get all the data you wanted, and also even transmit your anesthesia records.
So, sir, if I may just add for the benefit of all our delegates, that sir's point was it should be very well taken, because when you're buying in a new monitor, investing in it, it's always important that you know what are the kind of storage that is achievable. How do we get a printout? I remember at least a couple of cases where this kind of data has helped me in medical legal cases as well. So I think you should this webinar and this meeting and this question would be well taken, and we need to be investing in having the data available for us for multiple reasons at the end of the case. So please do talk to the provider, and there will be options available for you.
Yeah, and also some of these monitors will have a printing outlet. There is
Yes.
a port for printing. You can actually print out. And as you said, it is very important for the medical legal reasons, because if you have the data, and the data sometimes can help you in your favor. Look, this is what it is. This is what I did, you know. So it sometimes helps you to protect.
One basic question from Dr. Pooja: what is the difference between capnography and capnometry?
Capnometry is a digital value. That means it is a number. Capnography is a waveform and includes the number. So with the current standard of care or the current standard of technology, there is no more capnometry actually. It is all capnography, because the number sometimes may not give you a great idea, but when you look at the waveforms, it actually gives you a good idea about the clinical status of the patient. So therefore, the word capnometry is, in fact, when I wrote my first article in 1990s about end-tidal CO2s, I did write capnometry and capnography, but currently I think it is better to use the word capnography, because capnometry, where there is only digital recording, is available in some of the portable monitors to use it to do a stat check of an endotracheal intubation. Say, for example, you go to an ICU and put an endotracheal tube. You want to know whether, and they don't have a capnography unit. You put your small capnometry unit, it gives you a number, 36, with a bar. So that is capnometry, but capnography is the one that is currently used and should be encouraged. So the word, actually we can replace it now only capnography.
Excellent. I think, sir, I'll just reiterate the point that you were making, that observing the value itself is not the correct thing to do. As evolved anesthetists, we need to make sense of the trace, not only for the ETCO2, probably for the arterial trace, for the ECG, pulse oximeter. Everything is going to give you additional information. I think this lecture should motivate all of our youngsters to look more than the value, look into the traces and see the different shapes and the hidden information of the hidden treasure that is there in those traces. Uh, from Dr. Sonal, she wants to know, so pediatric patients show lower ETCO2 values. That's what her impression is. So what range should we consider normal in infant? Actually, there's one more question regarding pediatric. I'll come to that later, but this you would like to address, sir. You agree that the pediatric patients show lower ETCO2 values?
No, actually it should be more or less same. It should be not, because the CO2 normalizes very, very quickly after birth. And the reason why you see low CO2s on your monitors is your monitors are not specifically designed for pediatric use. You have to use a smaller pediatric cuvettes. And also, as I said, you must be using monitors with a side stream sensor with with a pump flow of 150 ml. 150 ml in a small child is little too much, and you have to use capnographs with 50 ml per minute as a suction pump, and therefore it is not that the children have low CO2. It is probably the problem is with the monitor, and that is where the technology like the Iridian technology or the microstream technology comes into play. You get normal looking CO2 waveforms, normal looking numbers in pediatric population. So for dedicated pediatric hospitals and the pediatric ORs, they should get the monitors that are more suitable for children.
Right, sir. One other question, I think, again, emerging technology. Dr. Ravi Kiran wanted to know about surface carbon dioxide monitoring principles, its advantages and disadvantages.
Surface monitoring carbon, I don't understand the question. I mean, what is your interpretation of the question?
So there is some talk about percutaneous monitoring or from transcutaneous monitoring of the carbon dioxide.
Okay.
I have no personal experience, sir, but
That's
should we
right.
get into it?
Okay. No, that's easy. So transcutaneous CO2 monitoring has been there, this technology, for has been there for a long time. In fact, even if you go back, in fact, I used transcutaneous CO2 monitoring in one of the papers in 1990s. The difference between, so it is like this, the end tidal to arterial is about 4 to 5 millimeters. Arterial to transcutaneous is again about 4 to 5 millimeters. Okay, that means the transcutaneous is slightly higher than the arterial. Now, when these monitors, when the transcutaneous monitor technology came in the late 90s and even early 2000, the technology was not all that great. I mean, the monitor works, then then it didn't work for a while. But however, I should say in the last 4 or 5 years, Centec, they have actually produced, they have brought up transcutaneous CO2 monitors, which are actually pretty good. And also they do not produce surface burns. You know that they have to little heat up the sensor in order for the CO2 to come from the tissues through the skin into the solution that is there in that sensor. And then is measured the transcutaneous CO2. So the current technology of transcutaneous CO2 is good. And so it can be used. In fact, there are a couple of papers which are published too, where they use the transcutaneous CO2 monitor in a morbidly obese patients receiving neuroaxial morphine for post-operative cesarean section delivery, and they found that the transcutaneous CO2 values were higher than 50, but there was no hypoxia in them. So yes, transcutaneous technology is improving with time. The new monitor seems to be fairly good, but somehow they have not caught up that well. In fact, the new transcutaneous CO2 monitor also measures the pulse oximeter waveform. So you take the transcutaneous and put it on the earlobe, it gives you the pulse ox and gives you the transcutaneous CO2. And the response time of the transcutaneous CO2 monitors are pretty good with the change in the CO2 status of the patient. So they will help us to find out a patient who is becoming hypercarbic because of administering post-operative narcotics for pain. So that's the current status.
Is it widely used, sir, in abroad or at your place?
No, actually, it caught up. Initially, in fact, as I said, I wasn't very impressed in the early 2000s. But now the last 3-4 years, the monitors that came out from the Centec, which is actually a Swedish company, I think, and they seem to be good. In fact, one of my colleagues was asking, could we use this transcutaneous CO2 monitor, in this to obtain, this organ transplant, during organ transplant, and to see whether there is any relationship between the survival of the organs and the values you get it from the skin. And they have not started the project, but as I said, it is not used routinely. It is still, people are doing some experiments, but I think it may be a good monitor for post-operative patients receiving narcotics, so that you can figure out that they don't go into too much of hypercarbia. But it is still not used as a monitor. I mean, even capnography has taken so long to get into our practice. And so probably in future the technology will improve, but not used routinely.
That's good, sir. Dr. Pasha wants to know, does the use of HMEF filter affect EtCO2 values, the heat moisture exchange filter?
Yes,
does it affect the EtCO2 values?
Yes, actually it could affect. In fact, I got an email from the Brigham asking me the same question, why I'm getting a little bit of a higher end tidal CO2 values in COVID patients. One of the reasons it could be because of the HME filters, and so yes, there could be a little bit of artifact, but may not be that clinically significant. I mean, we are not talking about of a big big difference in the CO2 values. A few millimeters here and there is not going to change our clinical practice.
So there are a lot of feedback from a lot of our delegates about how excellent your lecture was and how they enjoyed it. Uh, Also, there is a question about from Pasha, Dr. Pasha only about ETCO2 monitoring doing non-invasive ventilation, say a BiPAP or such. Is there a uh, role for monitoring or
Yeah,
possibility?
so what happens in the BiPAP is there will be some amount of dilution of end-tidal CO2 during when you give BiPAP. So the best way here would be you monitor the CO2 before you administer the end-tidal CO2 before you administer the BiPAP. Then you put the BiPAP on, you will see a difference in your value. So you have to take that difference into account, saying that, well, it was 60, but when I put the BiPAP, it is 40. Immediately, it is 40. This is not that his patient's value is decreased. It is because of the error, because of the too much of oxygen or the dilution. You take that as your baseline, and then suppose you give BiPAP for a while, and then you brought your value to say 30. If you want to cross check, you just measure the entire, take the BiPAP out and look, measure your end-tidal CO2 value and see where you stand. So it is not that easy when you use BiPAP, but
Yes.
you can use it as a trend monitor.
Trending monitor. I was about to come to. Yeah. Okay. An anonymous attendee wants to know. I think he's indicating about the inspired CO2, IMCO2. So how important is that?
Well, that is actually very important. I always look at it, whenever, as I said, whenever I'm extubating someone, I just look at the spontaneous values. And if there is a patient is getting breaths from the ventilator, I compare both of them. If certainly the patient breaths are much higher, the patient breaths are much lower than the ventilatory breaths, I know that probably, it is not ready yet. So I just tell the resident, just be patient, so yes, it is of value, particularly when you're doing the cases and even in the ICU settings, because ICU it is more common because they'll be breathing spontaneously for a while and then you decrease your respiratory rate. So it gives a good comparison.
Okay. I think also he was referring to that elevated baseline when the soda lime goes off or gets used up. Uh, any values that you find acceptable, sir, there, or we just for the changing of the soda lime?
No, the question is, if the baseline value goes up because your soda lime is your soda lime is getting exhausted, what is more important is your end-tidal CO2 value. If your end-tidal CO2 value is not increasing, despite partial absorption, partial use of the exhaustion of the soda lime, you are still okay. However, your partial exhaustion or the exhaustion of the soda lime is producing hypercarbia, that means increasing the end-tidal CO2, then you have to change it. So as long as it is not your end-tidal CO2, see your baseline gets elevated because of inspiratory CO2, because it is not completely. But however, your tidal volume is still good enough to blow off the CO2, and it is not, your end-tidal CO2 is not increasing, you're still good to finish the case and then change your soda lime.
Yes. Okay. So. Dr. Manjeet Singh Rajput wants to ask, does the inhalational agent, anesthetic agent, affect the capnograph significantly?
Yes, actually, that's a good question, and I didn't. I think I didn't include. I actually included nitrous oxide, oxygen. Yes, any polyatomic agents are going to. So every anesthetic agent absorbs infrared light, but however, they do it at a different frequency. I think they use a frequency of wavelength of 3 millimicrons on one side and a higher millimicrons, maybe 10 or 11 on the other side. So they are not really in the CO2 absorption spectrum.
Right, yes.
And what happens is, when there is the infrared light that comes, there is actually a filter. The filter specifically sends the 4.3 millimicrons wavelength to pass through. So it automatically takes all these agents. And lastly, the amount of the inhalational agent we use is a small concentration. So it should not really affect the monitor too.
So we come to the last few questions, sir. I know we have taken a lot of your time, sir, and once again I would like to thank you.
No, that's fine.
Rashmi wanted to know, does that alveolar dead space reduce after recruitment of alveoli? The PA.
Yes. Actually, yeah, absolutely. If you are doing good alveolar recruitment and your alveolar dead space, that is why your your pulse ox shows good improvement. When there is a hypoxia, you start alveolar recruitment, and then you say, oh yeah, I think from 95 now it has come to 97 or 98. And yes, it does. The alveolar dead space has a value there. See, that is the reason why, as I said, the newer ventilators in the ICU use volume capnography, and they non-invasively determine the bore's physiological dead space. So as physiological dead space decreases and normalizes, that means you're doing a better alveolar recruitment.
Dr. Swati wanted to know about EtCO2 along with HFNO. Are there any ideas that you could give us, sir? Is that doable, or is it
No,
work out well?
no. So the high flow nasal oxygen is going to affect your end-tidal CO2. So what you have to do here is intermittently you shut off your oxygen and measure the end-tidal CO2. So you're giving high flow, just shut it off, measure the end-tidal CO2 for a couple of breaths, and then put back. So you know where the ventilation is.
Right. Okay. I think, sir.
See, there's a lot of ingenuity, which as a clinician, you can come up with your own strategies of using. Once you understand how the capnography works, you can actually figure it out and come up with ideas of your own. That is how I learned from many delegates when I go for the meetings, and particularly people who are doing dental procedures and monitoring CO2, etc.
Excellent, sir. I think you have inspired a lot of our youngsters to look at these graphs in a more inclusive way, rather than just as a value to record on their data sheets. And let me just check if there's a question. I think again, sir, we've had excellent reviews, and everybody is saying that they had this hour and a half well spent with you, and everybody's happy to have seen you and listened and understood your lecture, more importantly, and look forward to. We would like to invite you again sometime in the near future, based upon, I know you're a very busy person looking after a big unit, and I know, and I want to recount sir's humility. But many years back, I asked him, a few years back rather, that why does he still do nights, though he's at a senior post. He still does nights with his juniors. I don't know if he does that now, but that was at Brigham's, and he said this is the only time that I can teach my juniors well. So he still does his cases and his calls, and because it gives him an opportunity to continue teaching. So thank you, sir, and I really sincerely appreciate all the things that you've done, not only today but all over this last few decades that you've been coming to India and inspiring and influencing so many of us. And I take this opportunity to thank you once again, and on behalf of all the people who attended today. Excellent webinar, sir. I really didn't think this Saturday could have been better spent. Thank you so much, sir, and I look forward to having you over with us at the MAPS webinar.
Yeah, actually, regarding the calls, I do take all my calls. In fact, I was called on day before yesterday, and I do weekend calls also. And in fact, I did a lot of COVID patients too. See, because particularly I'm the chief of OB anesthesia, if I don't take calls, people cannot respect, they won't have much respect for me. Because I take all my calls, no one questions my authority. Because I do calls, I do cases myself. I know what the difficulties are. Otherwise, what would they say? Well, what does he know? He sits at home and he doesn't know. So that question doesn't arise with me at all, because I do all my calls. I take care of the COVID patients too. And because that is the only way I can improve changes and then dominate respect from the colleagues. And then going back to one important thing which just stuck my mind, in 2006, I think I came first to Mumbai, I think, to do a lecture on capnography. And since then, I have seen a tremendous change, in the impact. I have met some anesthesiologists in 2009 and 10 in Mumbai. They said that they have actually the hospital bought the capnography units for them, even in private practice.
Yes.
And that is an important turnaround, yes. Improving standards of care. So that's the thing. So thank you, and have a good have the rest of the day. Good rest of the day.
Thank you so much, sir. You have a good day too, and we sincerely look forward to seeing you again very, very, very soon. Thank you, sir.
Sure. Thank you. Take care. Bye. Bye.
Yes, thanks, Shanaya. Thank you very much, all the delegates, for attending. I